Welcome, everyone. Thank you all so much for joining us this evening. You could have been spending your Tuesday night anywhere else, but you are here with us, and for that, we are extremely grateful. So talk to me in the chat. Tell me, where are you all calling in from? I'm reporting live from Atlanta, Georgia. And this is our first time hosting an Ask a Doctor event since 2019. And we're just super excited to be somewhat back to providing health education events that break down the barriers that Black people experience in accessing health promoting information and resources. So before we get started, I just want to go over some house rules for this evening. So use your chat function to engage with us. If you've never been to a Black Health event before, we'd love for our events to be engaging learning experiences for everyone. So feel free to ask any questions or post any comments throughout the session. Most importantly, this is a safe space. If you don't understand a word or a concept, please ask for clarification in the chat. It's cliche, but there is no such thing as a stupid question. Remember to have compassion and please be respectful while engaging in the chat. We'll be discussing sensitive topics that affect people in different ways. It is perfectly okay to step away at any point if the conversation gets too heavy for you. And just a heads up, this conversation is being recorded. So now that we've got that out of the way, a little bit about Black Health. So Black Health is an Atlanta-based nonprofit organization started by 4 friends who met in graduate school. Khadijah Amin, Matthew McCurdy, myself, Marcella Ryan Harris, and Paula Wheeler. We engage the public and health professionals on the impact of racism on Black health and then equip them to do something about it. Our events, workshops, and services are aimed for education and action. So I need to know how many of you all out there ordered your Good Down There kits. I know I got mine and I'm good down there. I asked this because this event is part of our amazing partnership with Cottonelle and the Good Down There campaign. We are working together to provide education and awareness and complimentary screening tests with the assistance of our amazing community partners. So Others May Eat in Washington, D.C., Trap Medicine in Oakland and LA, Change Happens Houston, Neighborhood Service Organization in Detroit, and the Babashi Transition to Hope in Philadelphia. We're also excited to be able to provide financial resources to Black people in need in partnership with the Colorectal Cancer Alliance. And this amazing partnership is all to really just help decrease barriers to care, increase access to needed resources, and reduce the stigma around colorectal cancer. So our event tonight is the first in a series of educational events that are a part of the Black Health and Cottonelle Good Down There campaign. So some of our learning objectives for tonight. By the end of this event, we want you all to have the fundamentals of colorectal cancer, including risk factors and symptoms to look out for. Know the role of racism on colorectal cancer access and outcomes inequities that Black people face. And finally, walk away with health protective actions you can take to take care of yourself and your colorectal health. So at this time, I'm going to stop sharing my screen and I'm going to bring Khadijah on stage to get us started with just some foundational information.
Yeah, great. Thank you so much, Mercy, for that introduction. That was great. And I wanted to start with a poll for the audience. So let's see if we could share. Awesome. So you can answer this poll on your desktop at pollev.com/FrankLight104 or by texting FrankLight104 to 37607. And the question is, what brought you to this event today? So I'll give a second for folks to enter their responses. If you're having any difficulties, you can also just put your response in the chat if you're joining via Facebook or YouTube. Awesome. Education. Great. Health equity. I've worked with Black Health. Hey. I'll give us a few more seconds. Awesome. Worked with Miss Marcilla on Project Hotep and saw her IG post. Oh, my sister's on the panel. Oh, awesome. It seems like Insight. I see Insight in the chat. I'm the outreach coordinator with one of the ambassadors at Change Happens in Houston. Awesome. This feels like a small family that folks know each other. This is so awesome. All right. That was great. Oh, one more. Hear the conversation. Awesome. Okay, so I'm going to, oh, you love Black Health. Thank you. So I'm going to transition us into our educational component of this event and start with some level setting on what colorectal cancer is and what the signs, symptoms, risk factors are, just to ensure that everyone has a base level understanding of the topic. So what is colorectal cancer? Colorectal cancer starts in the colon or the rectum. These cancers can also be called colon cancer or rectal cancer, depending on where they start. Colon cancer and rectal cancer are often grouped together because they have many features in common, like symptoms, risk factors, incidence, and genetic makeup. The greatest difference between the two cancers lies in the anatomy of the body and gastrointestinal tracts. While the colon and rectum are both part of the large intestine, the colon is approximately 5 feet long and the rectum is the last 5 to 6 inches of the colon that connects to the anus. Additional differences between the two cancers include that colon cancer is distributed fairly equally between the sexes, while rectal cancer is somewhat more common in men than women. There's difference in terms of the anatomy of where the cancers are in their development. So the blood supply, lymphatic drainage, and nerve supply of the colon and rectum are different, which impacts how the cancers metastasize or spread to other regions of the body. And there's also a difference in terms of treatment decisions related to surgery, radiation therapy, and chemotherapy. Colorectal cancer is the third most common cancer in the United States and the second most common cancer, common cause of cancer-related death. It is estimated that 149,000 people will be diagnosed with colorectal cancer this year. So common symptoms of colorectal cancer include a change in bowel habits. So this can include diarrhea, constipation, a change in the consistency of your stool, or finding that your stool is narrower than usual. Persistent abdominal discomfort, such as cramps, gas, pain, and are feeling full or bloated, or that your bowel does not empty completely. Rectal bleeding, so finding blood, either bright red or very dark in your stool, and weakness or fatigue, which can also accompany losing weight for no known reason, nausea, and vomiting. A risk factor is anything that raises your chance of getting a disease like colorectal cancer. Common risk factors for colorectal cancer include age. So your risk of colorectal cancer does go up with age. However, and this is really important, younger adults are can still get colorectal cancer, and colorectal cancer is rising among people who are younger than the age of 50. You're at higher risk if you have a history of polyps known as adenomas. If you have had colorectal cancer in the past, even if it has been completely removed, you're more likely to develop new cancers in other parts of the colon and rectum. If you have inflammatory bowel disease or IBD, which includes either ulcerative colitis or Crohn's disease, your risk of colorectal cancer is increased. Many colorectal cancers are found in people without a family history of colorectal cancer, but still, as many as 1 in 3 people who develop colorectal cancer have other family members who have had it. And lastly, many lifestyle-related factors have been linked to colorectal cancer, such as diet, physical activity, smoking, and alcohol use. But early diagnosis and treatment can greatly increase someone's likelihood of survival from colorectal cancer. If diagnosed by stage 1, the survival rate for colorectal cancer is 90%. That is why screening is a powerful tool to ensure early detection. There are several methods that an individual can take to get screened for colorectal cancer, and these include stool-based tests, so like the fecal immunochemical test or FIT tests, or the FIT DNA test. And so stool-based tests involve collection of a small sample of stool and a lab assessment of that sample for microscopic traces of blood. And as we mentioned before, blood and stool can be an early indicator of colorectal cancer. The other option and bucket of tests are direct visualization tests. So these include traditional colonoscopy, CT colonography, flexible sigmoidoscopy, or a flexible sigmoidoscopy with a FIT test. So traditional colonoscopies and sigmoidoscopies are more invasive than stool-based tests because they involve a bowel preparation, anesthesia, and insertion of a medical device, so a colonoscope or a sigmoidoid scope, into the colon to look for polyps, abnormal areas, or cancers. So these scopes can also be used as a tool to remove those polyps and collect tissue samples. A virtual colonoscopy involves the use of a series of x-rays to make a series of pictures of the colon. And from there, a clinician is able to then examine the x-rays for polyps or anything abnormal on the inside surface of the colon. So those are the two main types of screenings. Depending on the type of screening, you can get it done either in a clinical setting or at home or community-based settings. So for example, a lot of the stool-based tests, you can take it at home. And one of the benefits of the stool-based tests is that they can be done at home and do not require transportation to and from the screening site. In terms of frequency, recommended frequency for screening depends on the type of test you get. So frequency can range from every year. So for the FIT test, the stool-based test, or the GFOBT test, to every 3 years for the FIT DNA test, to every 5 years for the flexible sigmoidoscopy or CT colonography, to every 10 years for traditional colonoscopy. And so one of the benefits of the visualization tests is that they require less frequent screenings. And last, but definitely not least, are post-screening. So if an individual receives a positive result after any of the stool-based tests, or a positive finding is seen in the CT colonography, a diagnostic colonoscopy must be done as the immediate next step for further evaluation. If an individual has polyps detected during the colonoscopy, the physician will recommend when your next colonoscopy will be based on the number, size, and types of polyps that were found. The most important thing is to know when to come back for your next colonoscopy and do so on time. If colorectal cancer is detected on the examination, patients will be referred to obtain the proper treatments. Follow-up treatment for colorectal cancer may include surgery to remove the polyps, radiation therapy, chemotherapy, or medication, depending on the patient and the stage in which the cancer is caught. Ooh, that was a lot. All right, so who should get screened for colorectal cancer? So if you have no family history of colorectal cancer and are at average risk, the recommendation is to begin getting screened at age 45. And I want to shout out that today is a very special day. So the United States Preventative Services Task Force just lowered the recommended screening age for colorectal cancer for people with average risk to 45 years old. And that is huge. And I know several people on this call have been advocates to lower that age. And so I just want to say congratulations to you all. That's big in terms of health insurance coverage. And so, yeah, today's a great day. um, if you have a history of one first-degree family member with a diagnosis under the age of 60 years old, then you want to get screened at age 40 or 10 years younger than the age that your family member was diagnosed, whichever is earlier. And if you have a history of 2 or more first-degree family members with colorectal cancer diagnosed at any age, then you want to get screened at age 40, begin getting screened at age 40 or 10 years younger than the age that your family member was diagnosed, whichever is earlier. So for example, and this takes a little bit of math, if your family member, your first degree family member, so that's your mom, dad, sibling, was diagnosed at 53 years old, then you should start getting screened at 40 years old. And if you have a first degree family member who was diagnosed at 45 years old, then you should start getting screened at 35 years old. So this is why it's really important to know your family health history. And also it's important to begin your annual physicals so that your clinician can assess if you have any risk factors. Okay, so I wanted to transition to the impact that colorectal cancer has specifically on the Black community. Black Americans are 20% more likely to be diagnosed with colorectal cancer and have a 40% higher death rate compared to other racial groups. Black Americans are also more likely to be diagnosed with colorectal cancer at an early age and with a more advanced disease state than our non-Hispanic white peers. And there has also been a rise in early onset colorectal cancer in all Americans under the age of 50. Since 1994, colorectal cancer incidence in individuals under 50 years old has increased by 2% each year, but these numbers are even steeper for Black Americans. So for example, the late actor Chadwick Boseman was first diagnosed with colorectal cancer at the age of 39. All right, so we'll transition to Black Health's favorite topic, racism and its impact on colorectal cancer. All right, so we're going to our second poll. So again, you can respond on your desktop at pollev.com/franklite104 or by texting. So this is a true or false question. So text or respond A for true or B for false. Oh, race is a risk factor for colorectal cancer. Okay. I'll give some more time. Oh, it's a tie. Oh, goodness. Okay. All right. So we're back at 50%. So this was a trick question, y'all. So no problem if you got that wrong. So the answer is false. Race is not a risk factor for colorectal cancer. So this is something that we try to teach at any of our events, our Black Health events, is the difference between race and racism. So race is a socially constructed classification of people based on phenotypes, so our physical features. That means that race corresponds to no biological or genetic reality. Rather, race is a categorization that society invented. So humans invented race, and we manipulate it and retire it at our convenience. So people with common origins may share certain physical traits like skin color, physique, hair texture, etc. But these do not, they only constitute a very, very small portion of our genetic endowment. So if one of our main takeaways for this in most of our events is that race is a social construct with no that's not biologically determined, which means that it's not really a basis for a lot of the disease states that we treat it as a basis for. However, racism is a system of structuring opportunity and assigning value based on phenotype, so based off of race. So how does racism impact Black health? Racism is a fundamental cause of racial health inequity in the United States and globally. Physician and public health scholar Kamara Phyllis-Jones defines racism as a system of structuring opportunity and assigning value based on the social interpretation of how one looks that unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and saps the strength of the whole society through the waste of human resources. Racism operates in a manner that structures fewer opportunities and places inherently less value on Black people. Racism impacts the health of Black people living in the United States through several pathways. So cultural racism ingrains values, norms, and beliefs of Black inferiority that results in health harming institutional policies and practices, personally mediated discrimination, and internalized feelings of devaluation. Structural racism in public policy has created differential neighborhood, residential conditions for Black communities, and reduced access to stable housing, reliable transportation, healthy foods, quality schools, economic opportunities, and green spaces. So it's through these pathways that racism worsens the socio-emotional well-being, including our financial and spiritual well-being, diminishes mental health, and leads to increased morbidity and mortality for Black people. And these culminating effects of racism are a root cause of disparate colorectal cancer outcomes and incidence, onset, prognosis, and mortality for Black Americans. So this is a diagram of how racism is a pathway for disparate health outcomes. And so if you start on the left, you see racial discrimination, racism at various forms. And then as you start to travel to the right, you see how racism manifests in denial of goods and services, stress, and violence, structural violence. And then you see how that then manifests into poor living conditions, decreased quality and access to healthcare like colorectal screening. And it also starts to manifest into negative coping behaviors, negative health behaviors, and psychological and physiological stress responses, which then ultimately leads to disparate negative mental health outcomes like anxiety, depression, and then physical health outcomes. So there's a wealth of research around how racism directly impacts our physical health, from cardiovascular disease to disparate maternal health outcomes, increased blood pressure, physical injury. And so I think this is really important and just something that at Black Health, we really try to ground our understanding of really all health conditions and all health disparities, is that it is not biological race, because race is not biological, but it is all of the interplaying structural and interpersonal systems of oppression and structural violence that lead to Black people having worse health outcomes, including in cancer outcomes. Okay, that was a lot. So one more poll. So what is one way that you can think of that racism impacts colorectal cancer outcomes specifically? I'll give it a second. You can also put your responses if you're on Facebook or YouTube in the chat. All right, lower screening rates. Right, so lower screening rates, and you can go more upstream to less opportunities for access to screening. All right, poor treatment in hospitals, so quality of healthcare provision. Yes, definitely. Great, no access to resources. So again, limited access to screening, but also just other healthcare resources like health insurance. Yes, delayed diagnosis, so harder to treat due to lack of access and screening. Limited access to care. Great. Awesome. Yeah, these are so great, and I want you to keep thinking about this role of racism. And I'm actually going to stop. Okay, slower prognosis, diagnosis, and treatment. Great. So I'm going to stop sharing my screen as we transition to our moderated discussion. Awesome. Great. And I will wait a second to invite my co-host back on, Marcilla. Awesome. Hey, Mercy.
Thanks for that overview. That was great.
Yeah, no problem. So I am so excited to introduce our special guest for the evening and have a really engaging conversation with them about their personal experiences with racism and race and colorectal cancer outcomes. So I will start by introducing our first guest, which I have the privilege of introducing, Bishir Sylvain. So Bishir is a multi-hyphenate Haitian American actor, writer, director, and producer who plays EJ on TNT's hit series Claws and Willie on BT's hit series Bigger. A lifetime member of the Actors Studio, Bishir studied drama at Southern Methodist University and co-founded Ground Up and Rising Theater Company in Miami, where he grew up after immigrating from Haiti as a teenager. Next, he can be seen on the Netflix streaming series Black Summer. Bishir is also the husband of the late Shannon Sylvain, who has stage 4 colon cancer and was founder of Brown Sugar Rehab, a nonprofit organization that promotes education, preventive health strategies, and provides resources for colonic screenings. So yes, it's my privilege to bring Bishir up on the stage.
Hola.
Hi.
Hello. How y'all doing?
Good. Thank you so much for joining.
Thank you for having me.
Yeah. So I'll pass it off to Marcilla to invite our next guest up.
Yes. So I will be introducing Dr. Pascal White. She is an assistant professor in the Department of Medicine, Division of Gastroenterology at the Icahn School of Medicine at Mount Sinai. She is the director of Gastroenterology Clinic, where she is involved in the supervision and education of medical students, residents, and fellows. Dr. White conducts health disparities research on barriers in colorectal cancer screening. In February 2021, Dr. White, along with 10 of her colleagues across the U.S., co-founded a nonprofit organization called the Association of Black Gastroenterologists and Hepatologists. Dr. White's hobbies include reading, travel, books, and planning vacations, cooking, and playing golf. She currently resides in New Jersey with her amazingly supportive husband and 8-year-old daughter. Welcome, Dr. White.
Hey.
How are you? Thank you for joining us this evening.
Thank you for having me.
Awesome. And so I will start the conversation. And we wanted to start with Black experiences with colorectal cancer. So we'll start with Bashir, and I would love to hear more about your story and what propelled you to become a colorectal cancer advocate.
As you mentioned, I was married to Shannon Sylvain, and she was diagnosed at 31, a week before her birthday, her 32nd birthday. We were married for 4 years. After our first year of marriage, she had very small symptoms. She had like blood in her stool, and she thought it was nothing. She went to the doctor and for a regular checkup, and then the doctor asked her, "Hey, is there anything else?" And she was like, "Well, there's a little blood in my stool." And the doctor was like, "It could be anything, but just in case, let's just, have a screening." She did that, and they were like, "Well, there's something in there, so let's see if we could just do a colonoscopy." And again, because she's younger, we were all going, "Okay, that's fine." And once she had the colonoscopy, we found out that she was stage 4 already. And due to the mass that they found, they calculated that she was living with colon cancer for 8 years. And that pretty much, turned our whole world upside down, because we had no clue about the disease. We didn't know what it was. We never heard of anything of it. Just the word cancer alone was scary enough, let alone colon cancer. We did find out that it did run in her family, and yeah, it was. They gave her 6 months. And we took it upon ourselves to do a little bit more research and did we did radiation, and they wanted to start with us with chemo. We did the radiation, but then we totally changed our entire diet, and we were trying to go in a holistic way as well too. And I'm convinced that prolonged her life. She stayed alive for 3 years, and then we started doing chemo. She actually went into remission after a year. But then it went to her liver, and that was once it goes there because of the lymph nodes, because I think she had like 14 lymph nodes that were affected, and we kept an eye on that, but then it went into her liver. But the reason why I wanted to be an advocate to all this is because especially during what she was having it, the amount of information that we found, and also her, to her credit, taking on this battle of surviving and to tell people about it, because we realize that as African Americans, we have no idea of what's going on. We have no information. There's nothing out there for us, specifically for us, for where we could look and know about, what even a colonoscopy was, or different treatments or different things that are out there. So she took it upon herself and decided to start this company called Brown Sugar Rehab. And the reason why we call it Brown Sugar Rehab is because diet-wise, sugar is one of the main foods that actually, feeds the cancer. And so she wanted to make sure that, number one, we talked about a healthy diet, and also try to figure out a way to have screenings for everyone. And when she passed away, it was impossible for me not to be an advocate, because I would hate for anyone to have to go through what we've gone through, and also to lose someone that's special.
Yeah, thank you for sharing that story, and so sorry for the loss of Bashir. But happy you're continuing to work to raise awareness and get screening kits out. So Dr. White, no, colorectal cancer is known as a silent killer, which I guess is what kind of we saw with Bashir's wife having it for 8 years. Could you speak more about what that means and what signs and symptoms someone should look out for?
Yeah, absolutely. And Bashir, thank you so much for sharing that story. I think this is one of the forums in which is most impactful to hear these stories, to hear what other people have went through, so that we can kind of, it hits home in a different way. So thank you for sharing that. Yeah, so the silent killer portion of it, I mean, at the earliest stages of disease, colorectal cancer has no symptoms. And so that's where the term silent killer comes in. By the time that you develop symptoms such as rectal bleeding and or abdominal pain, change in bowel habits, or even unintentional weight loss, that's kind of clues that this is obviously A, no longer silent, B, that something's going on, and C, most importantly, is that you should get checked out as soon as possible. And so I think it's super hard in young onset colorectal cancer, because most of the time we see that younger patients have symptoms, and their diagnosis is delayed because they either don't know what to look out for, or they're just thinking that it's nothing and that they're going to kind of ignore things and it'll just go away. Whether it is benign or malignant, rectal bleeding is not normal. You just have to work up to see which one it is. And so that's one of the major things that we want to make sure our audience hears about, is that if you're having symptoms, definitely get that checked out right away.
Thank you. Yeah, that's definitely one of the primary takeaways we want folks to take from tonight. And I think that's why hearing your story and your wife's story be shared, on top of the news that we found out today about the lowering of the screening age by USPSTF, is really important, because we definitely need to encourage folks to be getting screened younger.
And yes, and that was such a big win for a lot of us, especially the ones that are either going through it or have been fighting to let people know, like, it is getting younger. And one of the things, I mean, I did that last time when we talked, and the reason why I always show an image of her is because I think people have this idea, when you think about cancer, when you think about sickness, you think that, oh, not me, right? But I want to make sure that people understand that this is her maybe after remission, and then it came back. And so the reason why it's so important for everybody to really pay attention to this, because I think in the Black community, we have, first of all, I mean, I'm going to speak for myself. I'm not going to talk for the whole entire, but like, I know how afraid I am of the doctors. Like, every time I hear doctor, I go, yo, no, I don't want to, I almost don't want to know that I'm sick, and rather find out later than going to the doctor, because number one, I always feel like they're trying to get something out of me, trying to get some kind of like, or they ignore it, or they don't tell me the full truth, or I have to investigate more. I still, this day, I still don't trust them. And it was a battle because, like I said, we had to really come up with a solution ourselves as well too, because they gave her 6 months and that was it. And anybody that didn't, it's so easy to fall into the trap of like, oh my God, 6 months, that's it. And then you give up. But we had to take initiative and go, you know what, let's look at some stuff. Let's see what else is out there and try these things in order for us. And she survived 3 years, which was incredible. So it's very important to understand, don't put an image into your head as far as what this looks like, because you look fine. And you don't know that this thing is literally killing you from the inside.
I'm glad you said something about mistrust too, because I think that is like the big elephant in the room. Whenever a patient comes in to the office, and one, they're not expecting to see a person who looks like me come into the door, right? So I always get this all the time. Oh, you're Dr. White? Yes, I'm Dr. White. So the first thing, the big elephant in the room is, am I going to believe what this person's telling me? Am I going to actually follow the instructions this person's going to give me? I think the doctor-patient relationship is so crucial, especially in our community, especially building that line of communication, that line of trust. And I think the more candid we can talk about this, and more open we're open about the fact that there is an element of mistrust that keeps people from coming into the doctor, and arm them with that information of what they need to talk about, what their agenda items need to be within that doctor's visit. I think the more progress that we're going to make as a community as a whole.
And I'm glad you mentioned that, because that was the one thing that helped, is because she was close to her doctor, her regular doctor, and was able to talk about, number two, you know what I'm saying? And not be embarrassed, because I think a lot of times we don't tell the full truth, and we learn you literally have to say exactly what's going on. You can't be like, hey, it hurts a little bit. It's not like, you have to be in detail. And thank God that she had that kind of relationship with her doctor that was just like, yeah, my stool's, a little bloody, whatever, and as far as being uncomfortable when it comes to your life, there's no question about it. This is not the time to be shy. This is not the time to try to, oh, I don't want them to know no, that's where you want them to know every business, especially when it comes to your health.
Great.
Absolutely. And a point that Dr. White, you had brought up in a previous call we had, is that only 4% of gastroenterologists are Black. So can you speak more about the role of diversity, or lack thereof, in the gastroenterology, hepatology field, and how that plays into colorectal cancer care for Black patients?
Yes. So I think what the funny thing about it is that statistic hits home so much for our group, the Association of Black Gastroenterologists and Hepatologists, because even amongst the 11 of us, we're kind of counting like how many more of us are in the United States. And so, first and foremost, having a diverse healthcare workforce benefits everybody. Yet for Black patients specifically, it has been shown that, Black patients are more likely to undergo invasive treatments or procedures when their doctors look like them. We've seen other studies showing that, minority healthcare workers are more likely to work in underserved communities or with, other underserved populations. And so if it benefits patients, providers in the community, it's a no-brainer, right? Diversity is something that we should be promoting, is something that we should be pushing forward. With that said, our group obviously has a mission in mind. Not only are we improving or trying to improve gastrointestinal health outcomes in Black communities, but we are trying to develop that pipeline of Black gastroenterologists and hepatologists who are going to take up that torch to really break down those health disparities within our community. And obviously promoting scholarship and promoting all of these things within academia helps to put our foot and our stamp on that map. And having 4% a gastroenterologist, 13% of the population in the U.S. is African American, and 4% of it is gastroenterologists. I think we can and we must do better. And it's showing that if we do so, that it's a benefit for everybody.
Yes, I definitely agree. I know I always try to find Black women providers especially, just because I do feel more comfortable. I know I had a personal health issue a few months ago, and I had to see 4 providers in one day. 3 of them were white, and the last one was a Black lady, and that was the most comfortable I felt the entire time. And so you both mentioned some strategies for people to kind of be advocates for their own health, but when people are in settings where they're not really familiar with colorectal cancer, like how to even bring that up to their clinician who might not look like them, who might not even think it's necessary, like what are some strategies that people can take to just be advocates for themselves in their colorectal health in clinical settings?
I think being very proactive is a game changer. So if you are sitting in your doctor's office and they don't bring up screening for colorectal cancer, then you should bring up screening for colorectal cancer. Now you are empowered with that information. This 45 is the new 50. 45 has been the age for African Americans for a minute. So this 45, it has been for everybody. Is something that pretty much came about in the last couple of years when we're noticing early onset colorectal cancer kind of rising and wanting to do stuff for everybody. But African Americans needed to get screened at 45 based on certain society guidelines. So for that, having that knowledge and having an agenda items, just because your doctor has a list of things that they want to discuss with you. You may have active medical problems that they need to get handled. And you also have to come with an agenda list of items too, such that when you leave there, you can say, okay, I'm going to check this off, and we talked about it, and that's that. Unfortunately, 15, 20 minutes is just not enough time. That's a topic for a different day. But at least if you come in saying, I definitely want to discuss these top 3 things, and you can leave there feeling accomplished. So definitely taking a proactive approach. And even as a physician, I go see my doctor and I'm like, man, I didn't even ask that question. And it happens to me. So it's definitely a human thing when you're standing in front of someone who's going to give you some type of health information that's going to, make a difference in your life. You can get kind of nervous. So writing things down, I frequently go to the doctors with my parents. And I frequently say, hey, if I can't physically be there, let me be on the phone, because there may be a question that you had that you don't remember that I can bring up for you. So also having that support system come into play is also a good idea as well, if you can.
And I would say don't be discouraged as well too, because sometimes you might not get the right response, and you're just like, all right, well, I guess I'm not going to ask anything. And that's the wrong thing to do, and like she said, it's just asking the questions. And it's okay to even bring it down to as simple as possible. You don't have to be graduated from Harvard in order for you to ask these questions. Make it as simple as it can, so you can understand it, and you have that right. Because I think sometimes we get intimidated and they'll just throw words at us and we're like, all right, that's cool. But, and we don't even know what it is. And we just nod and says, oh, yeah. And we're like, no, you don't know what that word was. Just ask them what that is, because for them, they're, it's just like anybody in any profession. They're going to tell you exactly, they're in their swag, they're in their lane. So they're going to tell you all these stuff, and you're sitting there like, yeah. And you don't know what they're saying. Might as well ask as simple as possible. And if you don't understand, it's okay. No one's judging you. There's no test. There's no cameras. It's only you and him or her.
Thank you for saying her.
Oh, for sure.
Yeah, I love that honesty. I did have a question for Bashir. So I'm curious just about the intersection of being Black, so race and sex, and how that's impacted your experience as a Black man and a caretaker, and then the experience of your wife, like as a Black woman. So I'd love to hear more about how you felt like societal expectations, or just racism or intersecting forms of racism impacted just your experience as a Black man and a caregiver, and then again your wife's experience as a Black woman and dealing with colorectal cancer.
Yeah, I mean, when you get hit with that news, you literally leave this earth and you go into another bubble. Like you don't have time. Time is precious, and as a Black man, as a Black Caribbean man who's hard-headed, it actually was a positive thing, because it allowed me to basically put all these ideas of what it is to be a Black man or even a husband, put it to the side and just be that, and just be a husband and be there for my wife and literally live out my vows. And when it comes to something that is that serious, especially when the first time when they give us that 6 month, it's a train. I mean, it goes fast. It goes extremely fast. Decisions are made right there. And so I truly didn't allow so much of society, like anything that was society standard, that was not my goal, because I was like, I'm here to take care of my wife. If people had thoughts and ideas, I promise you I didn't hear none of them. But for her, it was hard, because there was a lot of things that affected her as well too. Even her physical state, like she was so afraid to lose her hair. She was so afraid. She was just like, man, and God, spared her hair, man, and she still was able to get her hair done and look amazing. But and so as far as like the thing that really got me kind of upset is the fact both of us realized, status wise, we were lucky enough that we had really good insurance. really, both of us. And so we were very lucky, but we kept saying to ourselves, like, man, if we didn't have this insurance, or if we didn't, if we didn't have that, we would not be treated the way that we are. Because even with the insurance that we had, they still were giving us a hard time. Like, I don't know, I don't think that is. And I was like, and we came in just like Dr. White said, came in with questions. We were like, well, what about this? And what about that? I was asking that doctor every possible, different types of chemo, which one is going to be the best, because the thing that we have to start realizing is, like, every individual is different. And I think a lot of times we group ourselves into a group, and then we forget how specific things are. And so, like, when they were talking about the chemos and seeing how some certain things that she was allergic to, and then she had to jump to another chemo, and it was just like all questions that we had to come in and be very specific. So with all of that, for me, I really didn't allow myself to be discouraged by certain roadblocks that came through. And as far as the caretaking part, it's like an unfortunate gift that I got, because I got to become a real man, and in a sense of what God wanted me to be than what I thought or society wanted me to be, like, or myself, or the thoughts that I thought about, oh, this is what I'm going to be as a husband. Like, it was more than anything I could possibly think of to care and love someone in that state fully and truly. I was blessed, in a very unfortunate way. Yeah, I mean, that's all I could say about that part.
Thank you for that. That's a great perspective. And I know, you mentioned, going to the doctor and realizing you had certain treatment because, you had good health insurance. And so that made me think, Dr. Bashir, as a physician, what are some barriers that you see when people are seeking treatment for colorectal cancer? And what role do you feel racism plays in certain barriers that exist?
Okay. I think, so it's multifactorial in terms of the barriers. So we're thinking about, physician barriers, provider barriers. We can think about patient barriers, and then we can think of like health system barriers. So when it comes to like patient barriers, we discussed, the lack of knowledge, not knowing about when to go and see a doctor for certain types of symptoms. You mentioned about the insurance process and the lack of insurance in general. Some people don't have insurance, and they're navigating this system pretty much blindly with regards to where to go, how to get the help that they need. Not to mention logistical barriers of just having transportation issues or trying to get to the doctor. And obviously, the provider barriers come into play in terms of a lack of recommendation. So there could be providers who are not recommending certain screenings, modalities to certain patients, whether it be for lack of time, lack of reminder systems in their electronic medical records, or other implicit biases. And so all of these can come into play as a patient's walking into your office, and you have to kind of tease it apart. Like, what is the barrier for this particular patient to getting this treatment? And at times it could just come down to, well, we don't have time. We were discussing other things that are more pressing than, let's say, this preventive health measures. And so I think the role of racism in all of these barriers comes into the fact that it can interweave itself and touch upon all of these particular barriers through these inequitable systems that mutually reinforce each other, whether it's through the financial system, the education, housing, and even the healthcare system. It can kind of, it's interwoven within this patient story that you kind of have to tease apart and see what can you do as the physician in charge to help this patient attain that level of care. And I think it involves a level of interest, a level of empathy, and also it involves a level of awareness that patients may not always tell you what it is that their barriers are, but just asking them, do you have any questions, thoughts, or concerns? I always end all of my consultations with that question, because a patient may not have a question, but they may have a thought, and they most often have a concern. And so having all of these things put together, I think will allow us to really break down these barriers and really kind of get to the root of it, if it is indeed something that is rooted within the racism.
I have a question. Do physicians know of the programs that are out there that could help people? Like, because I'm not sure that if there's a list that they know of, like certain programs that are out there that, because we didn't know, we got really lucky to finding Colon Cancer Alliance and other programs that are out there that literally are specifically to help just people with colon cancer, period. But are physicians are aware of those things, or is it mandatory to have at least something to be able to tell patients, hey, here are the sites, here are some stuff that you could look at?
I think it really is institutional dependent, and I think it is physician dependent. A lot of the times, depending on your patient demographic, that may not be something that you need to readily think about. You know what I mean? Versus if you are treating patients in a certain under-resourced, let's say, area, that may be something that is readily available to you. But I think as a whole, I think all physicians should know that, especially as your primary care doctor, gastroenterologist, whoever's involved in your care, and it's very much a partnership. So it may not be because the physician's not looking for that particular resource. It may just be that they may not have found it, and that as a partner within this doctor-patient relationship, the patient, if you find it and you bring it to my attention, now the ball's in my court. How can I help you move that forward? So it very much depends on, how often the physician is encountering these types of barriers and what is readily available to them via their institution or even through their society memberships, that they're a part of.
Thank you.
Yeah.
Yeah, that was a great follow-up question, Bishir. And I did want to, as we are almost done with the open moderate discussion part, and we'll transition soon into question and answer. But I did, at the beginning of the presentation, cover some of the different colorectal screening options. And Dr. White, I was wondering if you could speak more about those just from like your clinical lens, and kind of explain the difference between the stool-based testing and the colonoscopy, a traditional colonoscopy, and if there are pros and cons to each option, and if like your risk factor or symptoms kind of influence which option you should take.
Right. So I think just as a general idea, when we're talking about screening, these are people who are asymptomatic. Once you get into the realm of I have symptoms, it's no longer a screening, it's just a diagnostic examination. So in this vein, talking about screening, that means you have no symptoms, and we're just going to kind of check out to see if there's anything that's brewing a little bit earlier so that we can take care of it. So we have non-invasive testing that you described in terms of your stool-based test, your FIT test, your stool DNA testing, in which you yourself are going to take home a kit. You're going to collect the stool within the kit, and you're going to send it off to the lab. And that lab will let us as physicians know whether or not they see either microscopic blood in the stool and or either stool DNA cells in there. If that comes back negative, if you have a FIT test, you do it every year. So these tests are not one and done. We like to say that this is a programmatic screening process in which if you start doing stool tests, then you need to stick with it and come back every year for a FIT, or every 3 years for a stool DNA test. Okay. If these tests come back positive, then you have to go to a diagnostic colonoscopy. That means that at this point in time, we've detected something abnormal in that stool, and we have to see with our visual test if there's anything within the colon lining that could account for it, whether it be a growth or a polyp in the lining of the colon, or God forbid, any malignancy. To that end, you also have your imaging test, your CT colonography, in which you will still have to do a bowel preparation. So even though it's an imaging test, you still have to cleanse your bowel so that the radiologist will be able to tell the difference between a bowl of stool or a polyp. And so you will have to cleanse your bowels. And in our institution, they give a little bit of like a tagged radio tracer in order to tell the difference between a polyp and stool. And then if there is something detected on the CT colonography, you still have to go through a diagnostic colonoscopy to see what is it that was detected on that CAT scan. If you don't have anything that was detected on the CT colonography, you can do that every 5 years. I like to say jokingly that sometimes all roads kind of lead to colonoscopy because it is one of the best tests. It's both diagnostic and therapeutic. We can see it and we can treat it. So if we see a polyp, we can remove it right then and there. But that would entail having to take a bowel preparation. So you'll have to most likely take the bowel preparation the day before the colonoscopy and the day of the colonoscopy. That would entail having a little bit of anesthesia at certain institutions where they put a little bit of sleepy medicine within your IV. And you're pretty much in a twilight state where you're not feeling any pain. And then we will insert the camera through the bottom all the way around the colon in order to check again for those growths or linings, and those growths on the lining of the colon. Afterwards, we tell you what we did and what we found. And if we found anything or removed a polyp, we send those tissue samples to the lab in which they'll tell us what kind of polyps you make. They can range from benign or malignant or pre-malignant lesions. And after that, we can say, this is when you come back. So again, it's not a one and done thing. You have to get that feedback from your physician to say, all right, when do I come back? Depending on the number, the size, and the type of polyps you make, your gastroenterologist will let you know when to come back for your next screening test. If nothing is found, then that's when we give you that 10-year stamp where you come back in 10 years to see us for a repeat colonoscopy. Again, the pros and cons to each, obviously. The stool-based test, you don't have to take a day off of work. Colonoscopy, you have to take a day off of work because you can't work the same day you get the anesthesia. Bowel preparation is not pleasant, right? You have to really cleanse your bowel really well so we can see that lining of the colon. So that could be distasteful to a lot of people. Also, the risk of procedure, right? So it's very safe and a very effective procedure, but procedures do have risks: risk of anesthesia, risk of bleeding, infection, or perforation. So all of these things we explain to our patients, but they have so many choices that the first thing that you really want to do to see the patient is, we have two types of tests. You can it at home, or you can come in and you can have a procedure done with me. And depending on that response, depending on what their barriers are, what their fears are about the test or not, then you can kind of have a real educated discussion about where is it that we want to get screened. And gastroenterologists say that the best test to get screened is the one that actually gets done. So if you're going to pick it, you got to actually get it done. And all of them pretty much are offered at this point in time is going to be covered by insurances. I'm super excited that the USPSTF made these recommendations at 45. And so now that you're armed with this information, you can now sit with it and see which ones would be good for you to undergo when you're ready for screening.
Sorry, I got one more question. I feel like I'm a guest. Would you say the goal, well, would it be an impossible goal where, because I'm thinking about it like getting your physical, right? You get your physical to check if anything's wrong with you. What would stop having a screening or the lowest denominator of testing to be done with your physical? Because I've had people, I've told them, I was like, hey, since you're getting physical, see if you could get, a screening. And then they'll go, and then the doctor will be like, nah, you don't need to do that. Mm-hmm. And I don't understand why that's something that a physician would tell somebody, especially if they're just checking. And they're like, no, you don't need to do that. And that blows my mind. And so my friend had to lie and say, oh, no, I have history in my family, just so she could get a screening test. So I'm wondering, is that something that is being discussed as far as like, hopefully we could get to a point where that is going to be part of the physical test?
So you're talking about like a stool test, or you're talking about
just a stool test of just testing to see, because it's getting to a point where, because of the age, because we're seeing it on younger folks, I'm wondering, why is it not something that should be done regardless, whether if you're 45 or not? Especially if it's that easy where they could send it to your house, you can do it. You know what I'm saying? Like, I'm just trying to understand that part.
So I think it's like a risk balance situation. So there are balances between seeing an effect on the population. Obviously, you're one of one, but when they look at these studies and see what the optimal age is for screening, they're looking at it from a population standpoint, where they're saying, well, what are the amount of false positives that we're going to find, right? Because we're going to worry a lot of people who are actually well. So every test is not a perfect test. So when you send the test, you have to know why you're sending it and what you're looking for. So if we send a certain amount of tests into the population, we're going to get a certain number back that's basically false positive. So these are what these studies are looking at, and what's the sweet spot between the risk of the actual procedure or test, the benefits of the test, and obviously the cost to the system. So all of these things have to go into play. I wouldn't advocate for anyone to lie to their physician. That's the surefire way there's something going wrong. If someone's going to lie to me and something happens during a procedure, I would feel terrible because my indication for that procedure is what you told me. So that element of trust has to be there whenever someone steps into the room and I talk to them. I trust you, you trust me. The other thing is that at the end of the day, the people who are coming in with young onset colorectal cancer, 85 to 86% of them have symptoms. They are showing you symptoms. Most of them are not asymptomatic. It's the older people who have these, these cancers that are early onset that are asymptomatic. Most young people are coming in with symptoms. So I would say, for the most part, if you're not having symptoms, more likely than not, you're fine. We are seeing a rise. It's small, right? Most cancers are actually being found in older people, but we are seeing that rise and we are taking it seriously, which is why we're lowering the screening age. But there has to be a balance between just performing tests just because, people just want to know, which could actually worry a lot of people who are actually well. So it's definitely a balancing act.
Thank you.
Yeah.
That was some great information, you guys. I can't believe we're at the end of the moderated panel discussion portion. And so this was really important. I'm glad this is being recorded because I'm definitely going to go back and take some notes. So at this time, I want to encourage the audience, if you guys have any questions for our panel, I see we have some already. So to start, Bashir, you have 2 questions. I'm going to combine them into one. So thank you for sharing you and your wife's story. Have you gotten a colonoscopy? If not, do you plan to get one at 45?
Actually, no, I haven't gotten a colonoscopy, and yes, I'm definitely not. I'm not even going to wait till 45. To be honest with you, I'm definitely not. I did have one when I had a really bad accident 10 years ago. And so they had to check everything. But it's been 10 years. And so I definitely want to at least get screened, at least doing that. But, I go to my physician, I ask, I make sure that, I tell him what's going on and I'm pretty honest with my stuff. So, so I'm like, he's like, it seems pretty fine. So, but I'm definitely not afraid to do so. For the reason to be more of an advocate and let people know the process. That's something I actually want to do, especially working with Brown Sugar Rehab and Colon Cancer Alliance. I kind of want to do something to inspire and tell people to try to if they really do have symptoms, how it's not that invasive. Because I think a lot of people are afraid of the procedure sometimes, and especially certain men are like, "What? They're doing what?" And I'm like, it's not. You're asleep. Like you don't feel anything. So that's part of the reason why I want to do it earlier than 45 as well too.
Awesome, thank you. Another question we have from Dr. White. I'm probably going to butcher this because I'm not quite sure what this all means, but it says, is there disparity with ONC or NCARE/case managers?
I saw that question. I'm not sure. You can clarify, that'd be great, because I'm not sure if she's talking about on oncology, nursing care, case managers. I'm not sure what the question was. I'm sorry.
Amy, if you're still with us, if you don't mind clarifying your question. One question we do have while we wait is, in general, what percentage of colon polyps are malignant?
So we have to think about it in terms of size. Like anything that's like less than a centimeter have like maybe a 1% chance of becoming cancer. As you get bigger polyps, your chances of having a malignancy within that polyp increases, especially as it's above 2 centimeters. And so that's one of the reasons why we send our polyps off to the pathology, because even though there's a slight chance that that small polyp may not have anything, it may very well have something. So you want to ask your physician, and when you get the colonoscopy, look at the report, see what size they were, what the pathology said it was. But definitely it's dependent on the size of it, and the bigger you are, the higher your chance of it having a cancer.
Thank you. And that's why I know you mentioned, different screening options and things. We have a question that says, can screening with the CT colonography help to increase uptake among the Black community?
I'm sorry, you were breaking up. Can you repeat that question?
Yes, it says, can screening with CT colonography help to increase uptake among the Black community?
That's actually a very good question. I think what we would need to do is there are so many studies looking at what would be the preference of screening within the Black community. Some studies say that they found a difference between, let's say, Black patients wanting more non-invasive testing versus their non-Hispanic white counterparts. And so I think what we would need to do is within every community kind of figure out what the temperatures are. Do they want colonoscopies and they just can't get it because it's just under-resourced, or can they actually have access to non-invasive testings like a FIT testing or stool DNA where it could be sent to your house? And so I think for the most part, making all the choices known within the community, and some places may not offer CT colonography. I mean, that's something that's just what it is. So whatever choices are in your community, having the ability to figure out what are the options available to me and what I feel most comfortable with is the starting point. And so whether it's CT colonography as a first kind of imaging, or if it's a stool-based test, whichever test it is, as long as it gets done, is something that is obviously the first step we want everybody to take.
Awesome. Yes, and so Amy clarified her question. She says, oncology nursing care, is there a difference in quality of care and nurse availability in the Black community?
I can't speak to that. I'm not an oncologist. It'd be very interesting to see, but I can't speak directly to the oncology nursing care and the quality of the care, unfortunately.
Mercy, I found one of our pre-questions, and this can go to both of you, but the question is, how do you recruit allies who want to create initiatives addressing healthcare inequities among people of color when surrounded by non-allies? So this question is around allyship and health equity work.
I can take that. I think for our standpoint, for our association for ABGH, we're always looking to partner and collaborate with different societies who are also recognizing the health disparities that exist within colon cancer screening, and really advocating for getting programs and different people involved within the community to try to see what we can do to target this disparity. It's one thing to say, well, we have a disparity in screening in this community, but we actually have to go to the community and ask them, what do they need help with? So it's one thing to say, we're going to help you, but we actually need the feedback, that partnership. So it's not only the institutions and these associations, but also partnering with community liaisons and community advocacy groups who are on the ground, who know what the pulse of that community is, and say, well, this is what we need, this is what we've been looking for, and to figure out a way to help. And so identifying those allies we can see through our different associations, through our different memberships, and obviously within the institutions that we all work in, finding people who are doing work that we are doing in order to amplify not only the statistics, but also amplify the solutions to those disparities.
I'm glad you said that, because Colon Cancer Alliance is literally doing just that. They're literally trying to find different ways, different approach to communicate with different groups, especially the Black community. And this is one of the reasons why Shannon having Brown Sugar Rehab, they met with Colon Cancer Alliance, and we definitely are excited to have a partnership with them so we could be a voice for the Black community. And, you know, and all it took is just doing the research. You know, there are so many programs out there, and programs that will help you with free screening. There are programs that are helping to try to help you fund for colonoscopies, because that's another issue financially, because a lot of people feel like, you know, I can afford it. And that's one of the issues that we're seeing, especially with this beautiful and big team that we have in Colon Cancer Alliance, that we're finding out all the issues that are coming up. And I personally feel like financial is one of them too, because it is expensive, and to not, you know, a normal income will not be able. I could see how you could debate whether or not to do it, just to see if you have anything, you know, and to find out that, you know, you have nothing, you're realizing that you know, spend some money for you. It may feel that you spend some money for no reason, but I'm just very glad that there are a lot of groups out there, not only Colon Cancer Alliance, but there's a lot of groups that are really coming together and wanting to, you know, tackle this monster. So we would love to have you, Dr. White, to come through and and discuss and share. No, seriously, because I think the more the merrier, the more the better, because it is very serious.
Yes, absolutely. Another question for you, Dr. White. Is there some correlation to be made between the rate of progression of polyps into cancer in African Americans?
So I could see answering that question two ways. I think that there were different people who looked at the different types of polyps that African Americans make versus other ethnicities. The way in which polyps are found, let's say, for example, African Americans have more, let's say, right-sided colon polyps than left-sided colon polyps. And you saw that diagram in which, for example, if you only had, let's say, a flexible sigmoidoscopy, you could miss the entire right side of the colon. So whatever that polyp is just kind of lingering in the right side of the colon and no one's detecting it. Traditionally, right-sided colon polyps are flatter and harder to detect on colonoscopy as well. So I don't know if there's any specific factor looking at the rate of progression, but in terms of detection of colon polyps and looking at things being on the right side more than the left and getting the right type of screening so that you can get them out before it progresses to cancer is something that we're definitely interested in looking at and studying.
Awesome. That was really helpful. And we did want to end our questions with one more, and this is for the audience. So this, Dr. White, MD Shear, how can folks stay engaged with the advocacy work you're doing? Just stay engaged with all the amazing work you're both doing around colorectal cancer in the Black community.
Oh, you give me first? Oh, good. Thank you. I think first and foremost, you can always go and visit blackandgastro.org. It's the Association of Black Gastroenterologists and Hepatologists website, in which we have resources, events, and we essentially want feedback in terms of how we can best serve the community and what could be our next kind of target to help educate everyone about colorectal cancer screening. And obviously, we have hepatologists in the group, so we're doing a NASH day that's going to be an event in which we can stay engaged with the community, talking about liver disease. That's very informative discussion. You can find that information on our website soon. And also staying engaged with me on Twitter, Pascal White1, and at the stomach.nyc on Instagram, in which things like the USPSTF guidelines coming out, a lot of my colleagues are tweeting about it on Twitter, and really, keeping up with, I guess, what is it that the community needs from us, and so that we can remain engaged and give back to the community as well.
For me, it's really following Colon Cancer Alliance, and also Brown Sugar Rehab, which basically will take you to Colon Cancer Alliance. And they are definitely on social media, which will definitely give you all the updates of all the things that we're doing. The website has numerous information about, from the disease to programs that can help, and really trying to figure out the best way to you know really stop this disease, and really trying to find genuine help, so you don't feel lost. I love that the Colon Cancer Alliance have section also for even caretaking, and be able to find people you could talk to, maybe counselors. I mean, it's out there. The information is out there. So if you just go to coloncanceralliance.com, or if you go to their Instagram, just Colon Cancer Alliance, you just literally type it up, and you'll see it. You'll see it come up. Brown Sugar Rehab, we have an Instagram. We do have a website, but again, like I said, we literally goes to Colon Cancer Alliance. But our Facebook or Instagram or Twitter, you'll see stories like Shannon's, and just personal stories that allows you to really connect and see people like ourselves too, so you can feel more relatable. Because a lot of times I feel that the information is very technical, and sometimes we tend to just gloss over it, but when it's a personal story, we tend to attach ourselves more. And that's one of the things that I feel that my contribution is going to be, and obviously more stuff too, but right now I feel like that's the best thing I could offer right now, is to really tell my story, and hopefully people could relate, and be able to go, okay, I got to take this seriously.
Thank you both so much. This was an amazing conversation, and Black Health did drop the links to Dr. White-Beshir's social media and the websites that were mentioned for you all to stay engaged. Again, they're both doing some amazing advocacy work in this space, so definitely want to amplify that. But thank you so much for this great conversation, and I would like to now transition back to our ending call of actions. Awesome, great. And so Black Health always likes to end our events with concrete actions that folks can take to protect their health and the health of their loved ones. So through Black Health, we have numerous ways that folks can get screened for colorectal cancer. So we were started the year, particularly in March, with distributing colorectal cancer screening kits on our website, and now we've transitioned to some on-the-ground kit distribution in Atlanta and Georgia. So if you live in the Atlanta, Georgia area, definitely stay plugged into that more grassroots work we're doing. As Marcella mentioned earlier, we are partnering with 5 amazing ambassador organizations in 5 markets across the U.S. So others might eat in Washington, D.C., Babashi Transition to Hope in Philadelphia, Trap Medicine in Los Angeles and Oakland, Change Happens in Houston, and Neighborhood Service Organization in Detroit. And I know some folks from those organizations are listening in tonight. But each of those organizations have been doing colorectal cancer education, as well as distributing 500 Black Health and Cottonelle screening kits to each of those markets while supplies last. So definitely stay plugged in to their amazing community-based work. And also, if you or your loved one have any medical questions or feel like you're experiencing symptoms, you can always reach out to our friends at Colorectal Cancer Alliance on their website or at their phone number, 877-422-2030, to get additional information. We also have on our website some educational resources and information that really goes through some of the high-level content that we covered during tonight's presentation. So feel free to check out our website at blackhealth.com. And you can find this landing page at blackhealth.com/Cottonelle. And last but not least, Black Health and Cottonelle have partnered with the Colorectal Cancer Alliance to create a dedicated fund to provide financial assistance to eligible Black individuals in need of a colonoscopy. So if you or a loved one can qualify for this fund if you identify as Black or African American, you do not currently have health insurance, or your insurance company will not pay for a colorectal cancer screening or colonoscopy, and you have a total yearly household income below 200% of the federal poverty guideline. So if you feel like you qualify, or if you want to send information about this fund to anyone in your circle, and Black Health has shared it in the chat with you all. But again, you can call 877-422-2030. So I wanted to end with one more poll for you all. And so the question is, what action will you commit to taking to take care of you and or your loved one's colorectal health? And so again, you can respond to our polls on your desktop at pollev.com/FrankLight104, or text FrankLight104 to 37607. So you can respond on this poll, or you can put in the comments on the Facebook Live or YouTube Live. All right, so one person, make sure my family over 45 gets screened. Yes, again, if any takeaway from this event, we definitely encourage folks to get screened. I'll wait for any other comments. Be an advocate for my health. I love that, yes. Sharing what I learned today. Thank you. Yes, please share all this content. Talk about colorectal cancer with my family. Start the conversation with friends, family, and my doctor with the goal of early detection and screening. Fabulous. Advocating patients to speak up. Yes. I see someone in the comments. I have my Cologuard kit, so I will make sure to send back the sample. Yes. Yeah, if you do any of that at-home stool-based kits, make sure if it's a kit that you have to send back the sample, make sure to do that. The follow-up actions are super important. But yeah, awesome. This was great, you all. So let me transition to our last slide. So again, thank you so much for joining us tonight. You can stay engaged with Black Health on our website, www.blackhealth.com. You can stay engaged with us on our social media. We're pretty active on our Instagram and Twitter and Facebook at Black Health on all platforms. And if you ever want to partner with us or engage with us on future events, please feel free to email us, engage@blackhealth.com. But this has been a great event, and we look forward to doing more events like this in the future. So thank you.